This is John Crosson dictating a video which will summarize the concept of nephrotic syndrome in preparation for the flipped classroom, which Dr. Mark Weber and I will do at the end of January. Nephrotic syndrome is an important renal disease which is characterized by significant proteinuria of 3.5 grams per day or greater, along with peripheral edema, hypoalbuminemia, hyperlipidemia, and lipiduria. All five of those make up the entire concept of nephrotic syndrome. However, similar disease processes will produce just proteinuria greater than 3.5 grams in 24 hours without some of the other clinical manifestations. In this situation, the proteinuria is considered nephrotic range proteinuria, and basically the same diseases will produce nephrotic range proteinuria as will produce nephrotic syndrome. Proteinuria in general is due to either an abnormality of the charge selective barrier or the size selective barrier of the glomerular capillary loops. The charge selective barrier is generally due to negative charges along the capillary loops, and the size selective barrier is due to abnormalities in the slit diaphragm residing between the foot processes of the podocytes of the glomerular capillary loops. There are five main causes of nephrotic syndrome which we will discuss in this presentation: minimal change disease, focal segmental glomerulosclerosis, membranous glomerulopathy, amyloidosis, and diabetes mellitus. Several other conditions will also produce nephrotic syndrome, but these are much rarer conditions. There are a number of medical conditions that are associated with nephrotic syndrome, and therefore anytime a patient presents with nephrotic syndrome, the clinicians need to investigate these patients for the possibility of underlying medical conditions. In a recent textbook of medicine, at least 19 different medications were listed as causing nephrotic syndrome. Frequently, patients who are atopic and have allergies will also develop nephrotic syndrome. Many infections are associated with this problem, along with malignancies. There are a number of multisystemic diseases, in particular systemic lupus erythematosus, that present with nephrotic syndrome. And at the end of this presentation, I'll talk about two metabolic diseases that particularly present with nephrotic syndrome. Now, minimal change disease, as the name would imply, generally does not have any abnormalities on light microscopy. It was originally called lipoid nephrosis because the main abnormality that was detected was the deposition of lipids within the tubular epithelial cells. In recent years, obviously, other abnormalities have been described, which I'll discuss in just a minute. Majority of children under 10 who present with nephrotic syndrome will have minimal change disease, and therefore often these children are just treated with steroids without a biopsy. However, minimal change disease can present at any age, and people in their 70s and 80s can present with nephrotic syndrome due to minimal change disease. Generally, males are affected a little bit more frequently than females. As I mentioned earlier, often there's an atopic history in patients who present with nephrotic syndrome due to minimal change disease. Patients with minimal change disease have relatively little, if any, red blood cells in their urine, and they tend to have a very selective proteinuria where they excrete just albumin, which is the smallest of the proteins that are usually secreted into the urine in patients where there is loss of protein. Generally, minimal change disease is very steroid responsive, although not always. This is a picture of a light microscopy of a patient with very severe nephrotic syndrome due to minimal change disease. And as you can see, this glomerulus appears completely normal, as did all the other glomeruli in this particular biopsy. There was no evidence of any immunoglobulin or complement deposition. And the only abnormality that is seen in patients with minimal change disease is shown on this particular electron micrograph. The blue arrow points to a capillary loop with the basement membrane readily identified, and the blue arrow is particularly pointing to foot processes which appear completely effaced and generally collapse. And if you look around in this particular electron micrograph, essentially all of the foot processes show this degree of collapse and effacement. This is the characteristic morphologic finding in patients with minimal change disease. A very closely related abnormality is focal segmental glomerulosclerosis. This particular disease process is also due to abnormalities of the podocyte foot processes, just like minimal change disease. However, as you see in just a minute, it is associated with distinct abnormalities on light microscopy. About 20% of patients with nephrotic syndrome, particularly over the age of 10 or 12, are due to focal segmental glomerulosclerosis. There is evidence that this particular disease is increasing in the population, and the reason for this is not particularly clear. Males are definitely affected more frequently than females. This disease process characteristically presents with hypertension, some degree of hematuria, and a different type of proteinuria where albumin along with much larger molecular weight proteins are lost in the urine. These patients do not respond very well to steroids or to other medications, and these patients, if they have persistent proteinuria, gradually go to end-stage renal disease requiring renal replacement. This is a picture of a characteristic pattern of focal segmental glomerulosclerosis, where the glomerulus at the lower left-hand portion of the screen shows evidence of collapse of capillary loops along with sclerotic changes, producing a scar that is characteristically segmental. In other words, involves only a portion of the glomerular tuft. The rest of the glomerulus looks quite normal, and there is a little bit of reaction of the epithelial cells around the sclerotic region of the glomerulus. There are actually 5 types of focal segmental glomerulosclerosis that have been described. The one I just showed you is not otherwise specified. This picture shows 2 other types. One, the perihilar type, where the sclerotic change is right around the hilus of the glomerulus, and the one on the right-hand side shows evidence of sclerotic change at the tip of the glomerulus opposite the hilum of the glomerulus. The importance of these different characteristic types of focal segmental sclerosis are that the prognosis of these patients varies. In particular, the tip lesion tends to have a much better prognosis than any of the other focal segmental glomerulosclerotic lesions. This shows 2 other types. The one on the left is the so-called collapsing type, where there is marked proliferation of the podocytes of the glomerular tuft. These are the visceral epithelial cells. The parietal epithelial cells are not proliferating at all. This is a type of focal segmental glomerulosclerosis associated with HIV infection. Some other viral infections also can produce collapsing glomerulosclerosis. This tends to have a very bad prognosis, and these patients go rapidly to end-stage renal disease. The one on the right is a much less common type of focal segmental glomerulosclerosis called the cellular type. It has been known for quite a while that there often is a circulating factor in the serum of patients with focal segmental glomerulosclerosis that damages the podocytes and gives rise to the nephrotic syndrome in these patients. In the original study, there were about 15 patients studied with this factor. The exact nature of that factor is still not definitely known. When the serum of patients with focal segmental sclerosis containing this factor is injected into rats, the rats rapidly develop nephrotic syndrome. Patients with this particular factor in their serum who get a kidney transplant will have extremely rapid development of nephrotic syndrome, and presumably this focal segmental glomerulosclerotic factor is reacting in some way with the podocytes of the glomerulus, giving rise to the nephrotic syndrome. In recent years, it has been suggested that a substance called soluble urokinase type plasminogen activator receptor, or SUPAR, is the cause of the nephrotic syndrome. However, other studies have not confirmed this, and so this is still a debatable topic. Membranous glomerulopathy is a different type of disease process which is associated with very massive proteinuria. Sometimes these patients will have 20 or 25 grams of protein in their urine in 24 hours. These patients will have relatively mild hematuria, but generally more than is seen in a patient with minimal change disease. Occasionally, patients with this disease will go into spontaneous remission, but usually this is a progressive disease process which slowly results in renal failure. Steroids, when given, may slow the progression of this disease process, but at the present time, no specific treatment is recognized as reversing membranous glomerulopathy. It is characterized by epimembranous deposits which contain immunoglobulin and complement. Patients are usually over 30 years of age, and again, males are affected more frequently than females. Somewhere around 25 to 30% of adults with nephrotic syndrome will actually have membranous glomerulopathy. Patients with this disease process are a little bit more likely to have an underlying malignancy than patients with other types of nephrotic syndrome, so these patients should have some sort of a general investigation to make sure they don't have an underlying cancer. As with all cases of nephrotic syndrome, a number of different disease processes have been associated with membranous glomerulonephritis, in particular hepatitis B. Multisystemic diseases, again in particular lupus, can present with membranous glomerulopathy. As I just said, many cancers will present with membranous glomerulopathy. Gold and mercury have also been described to produce membranous glomerulopathy. However, these treatments are not used very often anymore. This is a picture of a biopsy from a patient with membranous glomerulopathy, and the characteristic findings are that the capillary loops look uniformly thickened all the way around the glomerulus. There is generally no increase in cellularity of the glomerulus, and there is no inflammatory response to the process, and therefore there is no evidence of neutrophils within the capillary lumens. The characteristic finding on the silver stain shows that these uniform subepithelial deposits engender a reaction of the basement membrane producing spikes which come up between the deposits, and the spikes show as silver positive spikes on this Jones silver stain. These deposits contain immunoglobulin and complement, as demonstrated by this immunofluorescent study showing uniform granular deposits along all glomerular capillary loops. And then the electron microscopy is very diagnostic. This is a single capillary loop showing the capillary lumen in the center, the basement membrane adjacent to the capillary lumen, and then on the outside of that basement membrane are uniform electron-dense deposits, and one can see the basement membrane response to these deposits extending up between deposits pretty uniformly. Above these deposits are the foot processes, which also show fusion or effacement and collapse of the foot processes. So there is a secondary abnormality of the podocyte foot processes in membranous glomerulopathy. In 2009, a specific antigen was recognized as the antigen to which an autoantibody reacts and produces the majority of cases with membranous glomerulopathy. In this particular study, about 70% of the patients with membranous glomerulopathy showed an antibody to 185 kilodalton glycoprotein, which turned out to be the M-type phospholipase A2 receptor. This A2 receptor is located on the podocytes, and therefore the autoantibody crosses the basement membrane, reacts with this particular antigen, and produces the immune complexes characteristic of membranous glomerulopathy. Interestingly, this antibody is often just an IgG4 antibody, and to confirm the process, an eluate from patients with this type of membranous glomerulopathy will react with recombinant PLA2R, and so this now demonstrates convincingly that membranous glomerulopathy is generally truly an autoimmune process. Other types of membranous glomerulopathy are probably secondary to conditions like lupus and infections that I mentioned just a little while ago. Another type of abnormality that can give rise to nephrotic syndrome is what's now called membranoproliferative pattern of injury. This disease process is usually seen in a little younger people. Males are affected about equally to females, and about 10 to 12% of patients with nephrotic syndrome will have this particular pattern of injury in their glomeruli. These patients will often have significant hematuria as well, and therefore they can present as a mixed nephrotic and nephritic syndrome. Sometimes patients will have what's called a C3 nephritic factor in their serum, which is an autoantibody stabilizing C3 convertase, resulting in low complement levels in the patient's serum. If patients have only C3 in their glomeruli and no immunoglobulins, this is now called C3 glomerulonephritis. As with other cases of nephrotic syndrome, many different disease processes will produce this membranoproliferative pattern of injury, in particular lupus erythematosus, diseases associated with cryoglobulins. In particular, hepatitis C has been a common cause of this particular pattern of injury producing nephrotic syndrome. And so any patient with this particular disease process needs to be investigated for the presence of hepatitis C and or hepatitis B. Light chain nephropathy can do this. Patients with sarcoid occasionally will have this type of glomerular disease. Patients with cancer, sometimes we'll have glomerular diseases producing this type of glomerular abnormality. And also this pattern of injury can be seen in some patients with renal allografts. This is a picture of a patient with a membranoproliferative pattern of injury, and as the name implies, there is thickening of the glomerular capillary loops, as well as a significant increase in cellularity in this glomerulus, with increase in mesangial cells, endothelial cells, and also some neutrophils can be seen scattered throughout this glomerular tuft. The characteristic finding is seen on the Jones-Silver stain, where there is evidence of duplication of glomerular basement membranes in many places. What is happening here is that the outer portion of the capillary loop represents the original basement membrane, and then the mesangium extends into the subendothelial space, stimulating the production of new basement membrane, which is on the capillary luminal side of the capillary loops. There's a very characteristic picture of a duplication of the basement membrane on the left-hand side of the center of this particular glomerulus. A couple of the capillary loops, as you can see, have normal appearing capillary loops, so this is a process that does not necessarily involve all capillary loops. The electron micrograph is extremely helpful because in this particular electron micrograph, you can see a mesangial cell extending into the subendothelial space. On the right-hand side is a capillary lumen surrounded by an endothelial cell, and then the endothelial cell is widely separated from the glomerular basement membrane with immune complexes, electron-dense deposits, and exudation of material in the subendothelial space. And as you can see, many of the foot processes show flattening and effacement, like we see in essentially all of the cases of nephrotic syndrome. This is the characteristic finding in what was called type 1 membranoproliferative glomerulopathy, because it contains a large number of immunoglobulins along with complement. However, the terminology for the membranoproliferative pattern of injury has been changed now, so that patients who have both immunoglobulins and complement within the subendothelial space producing the membranoproliferative pattern of injury are considered to have the membranoproliferative glomerulopathy type 1 disease. And those who have just complement but no immunoglobulins at all have a disease process which we now know is due to abnormalities in the regulation of the complement system, primarily involving the alternative complement system. These diseases are now called C3 glomerulopathy. I will show you a picture of a form of C3 glomerulopathy called dense deposit disease. There are other cases where there's just C3 deposited in the glomerulus and no dense deposits and no immunoglobulins, and these now fall into a new category of disease process called C3 glomerulopathy. This change in terminology is shown on this particular figure taken from a paper by Degati from 2012. This is a picture of a C3 glomerulopathy, previously called dense deposit disease, because a good portion of the glomerular basement membrane is taken up by very electron dense deposits, which basically replace the basement membrane and produce this particular type of disease process. Probably the dense deposits represent some form of abnormal complement breakdown product, but this is still yet to be determined. This is a picture of a patient with a classic diabetic glomerulopathy, and it shows the characteristic Morphologic findings of diabetic glomerulopathy. In the upper left-hand corner is a so-called Chemisto-Wilson nodule, which is characterized by eosinophilic material in the center of the nodule, peripheralization of nuclei on the outside of the nodule, and open capillary loops outside of the nuclei. This particular process is almost diagnostic of diabetes mellitus. On the right-hand side of this particular slide, however, are two arterioles, one are afferent and one are efferent arteriole coming into this particular glomerulus, which show extensive hyalinization of the wall of the arteriole. This is characterized by loss of the routine appearance of smooth muscle in the wall of this arteriole, replaced by uniform eosinophilic material called hyaline. If both the afferent and the efferent arterioles are involved, it is diagnostic of diabetes mellitus. So the pictures you're seeing here cannot be seen in any other disease process other than diabetic glomerulopathy. So patients with diabetes, whether it's type 1 or type 2, will frequently develop nephrotic syndrome. Early on, they will begin to excrete very small amounts of albumin called microalbuminuria, which can be detected by very specialized testing. Therefore, currently, patients with diabetes, particularly type 1 diabetes, are being followed very carefully for the development of microalbuminuria, because we know that if they develop microalbuminuria and their diabetes is not brought under better control, they will develop end-stage diabetic glomerulopathy. However, there is some evidence that if these patients are kept under very, very careful diabetic control, the microalbuminuria will go away and the development of end-stage renal disease can be prevented in some patients. Once the patients develop more significant proteinuria in the range of 1 to 2 grams per 24 hours, these patients will inevitably go on to renal failure. We know that only about 50% of patients with type 1 diabetes develop proteinuria and end-stage renal disease, and so there appears to be a genetic protection of some patients with type 1 diabetes from developing significant kidney disease, but we don't really understand what that is. Once they develop 1 to 2 grams of protein in 24 hours, they will go on to renal failure within about 5 years. Almost all of these patients will have diabetic retinopathy, which is a good diagnostic tool in examining patients with diabetes. And we know that the amount of proteinuria correlates very well with the prognosis in these patients. The early changes in diabetic nephropathy consist of thickening of the glomerular capillary basement membranes. This picture shows a very, very thickened basement membrane in a glomerular capillary. And as you can see, the foot processes are partially flattened and effaced, just like we see in other cases of nephrotic syndrome. Finally, an important disease process that often presents as nephrotic syndrome is amyloidosis. The majority of patients with amyloidosis will have primary amyloid due to an abnormality in their immunoglobulins, where they have a monoclonal light chain production of one of the light chains, usually lambda. And the abnormal light chains form a abnormal type of protein that cannot be broken down and deposits as amyloid. Occasionally, patients with severe infections, underlying chronic diseases, will have what's called secondary amyloid due to the production of AA amyloid by the liver. Patients with amyloidosis usually are not hypertensive, but they have very enlarged kidneys, and if it's primary amyloid, the light chain abnormality, usually lambda, can be detected in the urine. So this is a picture of a glomerulus from a patient with amyloidosis, and it shows replacement essentially of the entire glomerulus by the abnormal protein, which produces a very, very characteristic light eosinophilic appearance to the glomerular tuft. The absolute diagnostic tool in amyloidosis is electron microscopy, where one can see these 8 to 12 nanometer protein deposits that replace a good portion of the glomerular tuft by these deposits that are not broken down. There are other diagnostic tests that can be done in amyloidosis, in particular a stain called Congo red, which is positive in patients with amyloidosis. The importance of making this diagnosis is that these patients almost always go on to develop end-stage renal disease. There is no specific therapy for amyloidosis, though some aggressive institutions are beginning to try more aggressive therapy in these patients, consisting of bone marrow depletion and allogeneic bone marrow transplants. This type of treatment generally is not very successful. Besides depositing in the kidney, amyloid deposits can occur in essentially any organ in the body, in particular blood vessels, the heart, the liver. And so this is a systemic disease which often presents initially as early onset nephrotic syndrome.